right, everyone. Welcome to another episode of the Consult Education Show. We're back for round 2 with Robert Lardner. So we're going to kind of dive deep into Robert Lardner, what makes you so special, and the things that that make you special in the treatment room. So
let's start with something that I know I've been enamored with, and I know you are too, and that is muscular chain. So if we just lay a little bit of a foundation, there was in the early 1900s, we've had Lovett, we've had McKinney, Logan in the 70s. Then you've had Andre Vleming and their group from Amsterdam in the 90s who've kind of anatomically mapped this all out. Mm-hmm. The Thomas Myers. Mm-hmm. So who have I missed in that? So who also has influenced you in the muscular slings and chains, and how do we utilize it in our assessment and our treatment?
Well, I think that we saw back in, back in Prague, we came across the chains that were being described by Moishishova,
yes.
The rib chains. So she was influential in showing the far-reaching consequences of systems in that sense. We can see the biomechanical links of muscles. If we look at the work of Myers, we look at the work of Fleming and so on, we see them trying to, and of course Stecco with
I left out Stecco. How did I leave that one?
And so on. So we see everybody trying to map out the continuity of function, both in a very biomechanical way, in terms of what is linked to what and how. So there we have a description. And then, of course, we saw a description from Voita, trying to show this developmental chaining, oblique chains, etc. And that's what we have. The question now is how to integrate it into a rehabilitation, movement strategies, and so on.
Mm-hmm. Yeah. Okay, so how do we assess it? How does Robert Lardner assess it? How do we train it? What are some of the things that you're doing to incorporate this knowledge of these muscular slings?
The first thing is this. I try to always imagine these chains. I try to see them in my work. I try to link up everything I'm seeing and assuming that everything is connected until I can prove that it is not. Because it forces me to see something in total. And then, again, because we can see the globality of changes of range of motion, for example, that is very useful. When you have an intervention and you see that the range of motion has changed in all 4 limbs, it gives you a sense of connectedness.
Sure.
Yes? Mm-hmm. And so it means then that when I am going to assess, I can look at, I can test chains by just applying resistance to different parts of the body. And see if the patient can resist at all. And
this is off weight bearing and weight bearing?
Yes,
Okay.
Yes. You can go through both off weight bearing and weight bearing, and you're looking to see what breaks down and what does not break down. Where do you see the breakdown? And then you have to use whatever technique you like to try to facilitate its integration. Now, sometimes one of the big things which I think is often missed is aesthesis. Aesthesis is the quality of feeling. People must feel in order to move. If you do not have that feel, that awareness of movement, you are unable to change it and you are unable to monitor it. So many times, as Yander had said too, he said inhibition, that kind of muscle weakness is very, very common, and it is often overlooked. So when you are looking at somebody, for example, the person is doing a single leg stance and his foot will not settle down during the whole 20 seconds you're watching. He's going from lateral to medial, back to lateral to medial, then too much. That's a problem. And I must find out why he cannot settle. He cannot find a center of a locus of motion where he can be more in control. So I must now start testing and seeing how far-reaching is this deficit. Is it just in his foot? Does it go up his leg? Does it go all the way to his shoulder? How is this going to work? So you must develop or devise a series of tests or provocations that try to give you an answer, and then you go, what if I do this or stimulate that, and do I see a change spontaneously in the balance function of the foot? Does the single leg stance settle down as I would expect it to? So you must really start to believe in these chains and to use them both in terms of assessment and treatment.
Robert, do you believe there's utility, and I had the same conversation with Carlos Stecco actually, in if we would all agree that utilization and the activation of these slings are important, does that also mean that potentially we'd be doing manual therapy on these slings to potentially get more length, to get more relaxation in these tissues? Have you ever thought of slings like in the manual therapy standpoint versus just the activation standpoint?
Oh, yes. The two go together. One of the things that we suffer from as human beings are contractures over time. We can contract, but it is not easy you can't actively relax and stretch something. You have to do it either by contracting something else or having someone else do it for you. Yeah, that's it. So when tissue becomes dysfunctional and can no longer just go back to its relaxed state when it's not being used, this becomes a problem. So you have to be able to assess those tissues that are contracted and need to be restored to their extensibility, ideal level of extensibility. Without that, you may not be able to activate the muscles that are inhibited in the tissues. It can be tendon ligamentous, where we know that some ligaments have a contractile component, fascia, and also, of course, inelasticity within the connective tissue of the nervous system, so that it won't move as far as it should to allow range of motion. We sometimes forget to assess these things because we are so bent on the fact that we should have some neurological sign that will indicate adverse neural tension, if we want to call it that. But I have seen people who don't have adverse neural tension. Why? Because they don't move far enough to feel it. They've learned how to avoid it completely. So they're not coming into you with signs of adverse neural. They're coming into you with signs of the compensation for it. So, for example, I have a player who can't let his shoulders relax when his arm is stretched out to play tennis, because by that time the adverse neural tension makes him raise the shoulder. That's it. But he never comes to me and go, oh, I feel something down my arm. No, he's got neck pain and a herniated cervical disc. But when you look at his picture, you start to realize from his posture that the fascia has not allowed him to develop his chest very far. And along with that, when you start to examine him, then you start to notice that the shoulder has to come up in order to allow the arm to abduct. If you hold the shoulder down, now he gets the radiating symptoms down his arm, and that you have. So, although he's been treated for his neck, that was a consequence of an inability to keep his neck out of the role of a secondary stabilization point.
So the debate kind of rages on too, depending on like what camp or silo you're in. Do you think that fascia can tighten on its own, or do you feel like, you know, the muscular system is what is creating tightness there? And the reason that's kind of a fundamental question, in my opinion, is it would guide the treatment. You know, like, because I mean, we have certain people in the world that are saying, you know, that fascia just needs to be specifically treated on its own with kind of a neglect to the muscle connection. And then you have the people in the muscle camp that are like, we don't need to do anything with the fascia. We just need to work on, you know, better tone of the muscles.
Yeah, it is my experience that fascia, of course, you can injure it, in which case it will discard and will start to contract. But in many cases, the muscles, fascia being the railroad system that helps to keep trains in line so they don't veer off into the surrounding countryside.
Get the best analogy.
It's so good.
So fascia develops to guide, to help them not work so hard. It helps to streamline the movement. It says, don't go too far there, don't go too far there, you can stop here, and so on. So if the muscle, for some reason, or the muscle function becomes inefficient and starts overloading the fascia, it thickens, it tightens, because it must still perform its job. So when it comes to treatment, if you usually have to treat not only the fascia, if it is there, but you have to treat the muscle, because it has to stop overloading the fascial system so that the fascia can remain elastic and do its job. So I'm never for this either or extremes, because they're just, it's laziness. Do what you have to do.
Right.
Stop trying to make one thing fit all.
Right.
Why can't you treat the muscle and the fascia? After all, we've been treating muscles for years with good results, and we can treat the fascia with good results, but treating the fascia does not negate treating the muscle or the other way around.
Right.
You must find out what is wrong. For instance, many women develop thoracic pain as a result of deep pectoral fascia tightness. They may have great range of motion in their pecs, but over the years, the weight of the mammary glands and the use has allowed the deep pectoral fascia to become really tight.
Right.
You have to treat the fascia. Now, if the pecs are tight, then you'll treat the pecs. But if the pecs are not tight, leave them alone. So it's really just logic to me. Rather than taking a stance, do what you have to do based on your assessment.
Now, Moshe eloquently described these muscular chains and how they link up, how extremity problems can manifest themselves in rib dysfunction, vice versa. Do you 100% buy into Moshe Shiva's system?
I buy into the fact that many tensegrity relationships exist, that there are ways in which you can assess relationships and find out if there's a relationship that works in terms of intervention. Is it important that she's correct in every aspect? Not at all. The principle is that you have a strong response of treating afferents to the ribs on the extremity. That's the principle. That is where it starts and ends.
Right.
Then you can use that. If you can find a relationship through the trigger points or limited range of motion or symptom display, you find that relationship, you gather your data, you intervene, you reassess your data, and you get an answer. Is this worth pursuing or not? If it is not, you don't do it. If it is, you do it. Exactly. So these discoveries should serve as templates for action, not Bibles. They are templates, they are suggestions, this is what I see. And from then on, it is the practitioner's responsibility to test it and use it as a living template and not a biblical reference.
Sure.
Yeah.
When you're doing your trigger point or soft tissue assessment, are you looking for how these trigger points are linking up in the body?
Yes,
Okay.
because they are showing you avenues of tension. Because that's how the that's how the brain uses the body. It is using chains to affect movement. So when there's dysfunction, it is linked up in the dysfunctional chain, and you follow the main track of this dysfunction through its expression in trigger points, tender points, altered tone, and also altered texture. Yeah.
I think trigger points, they're so fascinating to me, you know, because like finding out what the actual cause of a trigger point is so multifactorial. I've had some good conversations with Shacklock about, he actually is the one who introduced it to me, the Kingery effect, where if you have nerve root compromise, whatever muscles are being fed by that nerve root will potentially house trigger points. So So it's kind of complicated. It's one thing to be able to palpate them, and it's another thing to understand their etiology and their edifice and how this all started.
That's right, and that is why you must keep in mind that you are dealing with different tissues that can all contribute to this expression. So you are not to jump on any one finding as the cause for treating it. That is very poor, and it comes you back to Levitt. Do not treat the site of pain. Use it to find out if there's anything else involved. And only when you are sure there isn't, you can treat that point.
And just to make it more difficult, we can't exclude the viscera as a cause of tension, tone, trigger points, eventually joint blockage. And you know, as if our job wasn't hard enough, now you have to...
You have to expand and force yourself to have this broad vision all the time. It would be nice to narrow it down, but you do so at your own peril. You must, despite all habit and desire, do not become myopic in your conclusions about what you're seeing. Just because the last person dragged their leg into your clinic and had it herniated disc does not mean that the next time you see somebody drag their leg in, they have a herniated disc.
Well, I think we kind of circle back too on like the importance of the auditing process, because we can get rid of a trigger point right now by sticking a needle in it. So, you know, are they able to maintain the changes that you're doing? And that second audit, the next time you see them, may be the most important one, because then you're getting a better window in whether or not you've actually gotten into the key link.
Do not kill your indicators by treating them.
That's so true.
You don't. You must be very careful not to start treating indicators that you turn off the smoke alarm does not mean the fire is extinguished. You just turned off the smoke alarm. Now you're in trouble because now you don't know where the fire is until something else rings. So you must, again, prioritize your treatment in such a way that you are keeping it open until the body forces you to look at a particular area and says, somewhere in here lies the problem. Then you treat that problem. But until then, you have to be careful because you have a roadmap of indicators and symptoms that will point you in the direction. But if you start treating the very indicators and symptoms and eliminating them, well, there's no way to point you to anything. You could end up at a cul-de-sac, and that will be the end of that, until someone else comes along and can reignite the inquiry.
Is everything that we're talking about, is that what led you to your nociceptive exam? And our listeners might not know what this is, but you introduced it to me when I was very young, 18 years ago. And basically what this is it's a couple of key points throughout the body to assess their pain threshold in those certain points. Did you create that nociceptive exam in a way to try to examine these trigger point dysfunctions that we're talking about, or was there another reason for that?
The nociceptive exam was actually created by John Iams, and it was an aha moment for me, because despite having seen Travell and all this, and seen this Moishish demonstration of trigger points, it was this simple, elegant way of going, wow, yeah, just get into the habit of palpating a group of trigger points every time, rather than be mesmerized by randomness of trigger points. Well, because if you get mesmerized, you'll run into trouble. You have to have a standardized approach. Even when I say, okay, let's do a DNS position to test, you must standardize it so that you can reproduce that same test in that same person again to see what changes have taken place. So you have to standardize your examination to as much as you can, even if the pool of components which you put into that examination change, but you must have a standard way of administering that exam. So the trigger point, the nociceptive trigger point idea came from John Iams. He had it, and then I modified it over time, depending on what I really was interested in.
And it's in this book, right?
I think it is.
Maybe we'll attach it, because I do think this is it really helped me out a lot.
Yeah, it gives you a basis to say, okay, this is the current status. I'm going to do this, and then I'll go back and have a reassessment of the global effect of that intervention. And that reassessing of global effect is much more important than local effect. Local effect can be very transient, and local effect gives you the indication that it has not made any big impact on the central nervous system. Because the central nervous system is like the Wizard of Oz. I mean, you have to make it speak and pronounce on something. It has to say something to you back. And if it doesn't, well, it hasn't noticed it.
Right.
So you have to go at it again.
Do you utilize dry needling or anything for trigger point therapy? Yeah.
Yes, I think it is very important. Sometimes it is kinder to the patient than your thumb.
Right.
You can only go so deep, and then it's just not feasible. But the dry needling is elegant. It will go far deeper than you can reach, and there's much less resistance to it, and it is quicker. So it is important to have access to different techniques that will allow you to reach different depths of tissue.
Now, in Levitt's body of work, one of the modalities that he talked about being able to remove trigger point from a muscle would be PostIsometric relaxation. There's been some critics as the years have kind of passed by that have said, PIR is more like spinal cord reflexes. Therefore, maybe it's not truly changing the trigger point long term. What do you still utilize PostIsometric relaxation or not?
Sometimes I do, but I think that at this point, there are so many things you can do that there's no honor in just using one approach. The quest is to summate the afferent input. So I may use post-isometric relaxation, but I will usually layer on other techniques that are aiming to get to the relaxation of that trigger point. We have, and the two principles that I think of very much are reciprocal inhibition, co-contraction, and of course you have autogenic inhibition. Yes. So in PNF, all three are utilized. So why would I just throw out two and lose one?
Right.
I have co-contraction functions where I'm using the antagonist to inhibit the agonist. I have reciprocal inhibition where I'm doing the same thing, but in co-contraction I'm using both to activate and even out their tone and relax and see what happens. In reciprocal inhibition, I'm using one activity to inhibit the other, and then I'm using tiring out of that muscle to inhibit itself. So there's three techniques of practically equal weight, and probably I think the ones that involve other muscles is more important than the one that only involves the same muscle. So I would say that co-contraction and reciprocal inhibition are very powerful. They're probably more powerful than post-isometric relaxation because they are involving more loops within the system to affect that. And therefore you are speaking to the wizard.
Directly.
Yeah, you have
Let's regroup on muscle testing. So I think what we need to do is we probably need to have you produce an argument for our listeners on why that should be part of a routine assessment. And I know you've been heavily influenced by MAT originally, I think with Roskopf, Bueller, yes. So let's start the conversation on muscle testing.
The phenomenon of muscle testing is one of circuit integration. Can the muscle meet your resistance in time and space? I don't, so much is bandied about, again, just like manipulation. Manipulation is mobilization. Then you can infer all the other things about it you like. It is the same thing with muscle test. A muscle test asks a muscle to ramp up its force in a timely fashion against a foreign force. That is all. And I want to know, is the activity well coordinated enough that it can do so? Basta. Now, what I infer from that test is quite a different matter. I find that a muscle has an inability to keep pace with my increased resistance. There is a problem with that muscle. Because when I have a muscle that is not affected, it can keep pace, and it can keep pace every time. So all I am asking is does this muscle have the integrity and the ability to ramp up its resistance in time with my own applied resistance to the lever it's attached to? And then I have an answer. And this is the difference between inhibition and weakness. If I get a muscle that cannot do this, and I try to facilitate it, and it still cannot produce force, I know it is weak. But if I facilitate a muscle, wake it up, and I redo that test, and the test comes back strong, meaning the muscle is now able to do that, I consider that muscle to have been inhibited. So that is really the difference. The importance of why would you use this? Because many muscles can be inhibited, but they are not weak. They are unable to produce force, but they're not unable to produce force because they don't have the potential to. They just do not have the coordinated ability to master the fibers in time to produce the force. And the treatment for that is very different from the treatment for a muscle that is weak, which means it has not even the potential to produce the force because it cannot. It has maybe not enough fibers. They all work hard, but they are not strong enough.
So we have hundreds of muscles in our body, Robert. So how do we of course can't test every muscle in our body. So what are some of the key muscle tests that you would do on a routine examination?
I tend to test, the muscle tests can serve two things. One, it can be a test of the muscle itself. I just want to know, does this bicep work or is it inhibited? I can also look at this inhibition because I'm going to find out if this, I just want to know if any muscle in this quadrant is inhibited or
Right.
Yes. So I may be just looking for data. Is there any weakness in the right arm? And so I test a few muscles, and I look for that. And I test muscles that are often used, okay? Or I am looking for an indication of nerve involvement. So somebody has sciatica, and I go, well, he doesn't seem to have pain much past the knee, or it's beginning to get to the knee. But I need to know if the motor function in that leg is impaired at all, and could it be related to his beginning sciatica. So I will test distal and proximal muscles to see if there's any weakness, so to speak. And when I treat the back, I will come back and retest those muscles. So I won't treat the weakness that I find. I'm just using it to find out now if my intervention on treating the back has that far reach.
Good audit.
Because it is not... I remember once we had a discussion where if you, let's say that patient came to me and he had no symptoms past mid-thigh, and he says, I want to go skiing. Can I go? Well, it would depend on the integrity of the strength he has in that leg. And I would not send him and go, well, you can go skiing because I'm just going to give you some cobras and you can go skiing. Because what if those tests did not improve with the cobras and were not related to his back? And I send him skiing on a weak leg and he gets injured.
There's his ACL or
Therein lies, I have been an incompetent therapist. Now, if I tested and gave him cobras and the strength came back to his leg, I say, well, probably you can go skiing, just do the cobras, because that will keep your leg strong.
Right.
Yes. So there is a responsibility in making sure that you have done sufficient data collection so that you do not leave your patient exposed to risk. So muscle testing is very sensitive. It is one of the most sensitive things you can do easily. There are many other physiological metrics that you can use, but they're not easy to do. I can, pupillary reflex back and forth, or blood pressure, heart rate variability are not easy things to do with one patient after another, after another, after another. They are too specific, and you will need equipment, But a muscle test, you can learn to muscle test in a day.
In MDT, they teach something that's pretty fascinating, where if you have somebody who's got a directional preference in their back, let's say, and you check hip abduction, once you determine if they do have a directional preference, you can make that patient strong again. Let's just say extension was the directional preference. But then if we go back and we flex them, then you can immediately make them weak again. What's the mechanism?
It seems to be a mechanism of nociception, that once you introduce nociception, the thalamus has to decide what has priority. And nociception has priority over many other functions. So the explanation that has been given is that between force production and incoming nociception temporarily wins. And therefore force production is compromised for a time.
So you're not bought into that this is like a disc nucleus moving thing, right?
No. It is too subtle, and it would confound the very findings that the NDT program itself has come to find, because there is no indication that there must be a honking herniation or bulge at that point for the muscle.
And the McKinsey people wouldn't say that. I was just curious to throw that out there.
This is I would say a purely neurological relationship. It is not a biomechanical relationship, because we have always looked at nerves and the muscles they innervate as the only relationship that occurs. And yet we know this is not true. I can have an upper cervical problem that gives me weakness of my biceps. And we know that the innervation is not linked to the bicep.
Exactly.
Or I can have a lower cervical problem that gives me weakness in the deltoid or some other muscle that doesn't really biomechanically make sense.
Right.
And yet it's there. And yet when I treat the neck, the weakness disappears.
Right.
So we must be humble enough and be open enough to these relationships that we do not understand, but which have a phenomena that can be repeated, that is reproducible time and time again, because that is what gives you information that someone else may miss and can be vital to treating the patient in front of you. Because they may not be able to give you that kind of data because they're not even aware that it exists at the time.
Interesting.
Yes.
There's been a resurgence in muscle activation technique recently, because there's a famous golfer, Bryson DeChambeau, who uses Greg Roskopf. So, and I think this is where we get to like a critical crossroads in the conversation on muscle testing, which is, okay, so you've found a muscle that is testing weak. What's the intervention? And I know muscle activation technique, they have their own protocol. In Robert Lardner's paradigm of treating the patient, once you find that weakness, what are your tools that you now use to reintegrate that muscle in? And I know that's a broad, it's a broad question, but
okay. As I said, the weakness found is an indicator until it is not. So I must first rule out that there is a spinal cause for this weakness. That's automatic. And then I must also keep in mind that there's a tensegrity cause for this weakness, meaning that the patient doesn't have the stability enough to produce a good leverage, cannot access leverage systems to give me my strength in that plane. So that is why the treatment sequence is kind of fixed. I must unravel the posture. I must restore postural alignment in some way. And I must improve the bracing function. And then I retest and see what is going on. Because if I've improved those two things, and that weakness is just due to those two constant stresses, then I have an answer. If not, then I rule out the spine. And then I come to the more regional areas and then local. And I always do that in that sequence, so I'm not jumping to conclusions about the findings about the muscle test.
Okay.
That's
Perfect.
Because otherwise you will get lost in the weeds, because you start acting on the muscle test itself. The muscle test is a muscle test. It doesn't tell you anything about the muscle. It doesn't tell you. It just says, I can't produce force against your force in this position. End of story. What should I do about it? I do not know yet, until I prove to myself that all other systems are pretty okay, and this is the problem.
And I think all this information is probably culminated into your DNS manual therapy course. And Taylor's attended it from beginning to end, so maybe he could jump in here too. How has that class evolved? What made the class evolve?
The class evolved from my clinical work. I thought that it was necessary to teach DNS, but it was necessary in the clinic to show the integration of different principles that really go into treating a person. You can't choose one aspect and just use it. It is not very effective, because the person who comes to you often has multifactorial problems that are layered one on top of the other, and you must be prepared to sort this out. And it ranges all from the physical to going, you know what, this patient has a more psychological problem than they have a musculoskeletal problem, and make the appropriate suggestions for referral to somebody who can help them better. So in so doing, I thought you need to present the awful truth that it is not as simple as just putting somebody in a squat position or putting somebody in a creep position and hoping for the best. People come to you with often very strong problems, and by strong I mean their contractures are years old. These are not kids who will easily give up their muscle patterns with a little encouragement. You're going to have to fight them all the way to the bank to get them to give these patterns up. They have to become aware that they're there, and then you have to give them strategies to break this down over time, because they are not in habilitation, they're in rehabilitation. They've already acquired some bad patterns.
The great clinicians do this too. The next level down a clinician, they're constantly working on their patients' compensations and adaptions, and that's, oh man, is that ever a fragile
That's
subject?
right, don't work on those.
Right.
They're not going to help you. So for instance, I mean, when you look at gait, can you weight transfer from one side to the other efficiently? I can walk you on the treadmill and tell you how much you should lean forward and tell you to swing your arms. It won't help, because the basic building block of weight transfer is not functioning.
Right.
So that was my frustration, and I thought, it's nice to teach parts of this. You can teach technique, but you should teach principle. You should teach how to think about something and how to order and structure something. At least, if you show that, the person can go home using very different tools, but still order and structure it in a way they can use. So it is an example. Again, it is not a Bible. It is an example of how you can look and think through the problem that you're seeing and how you can structure a treatment, whatever that treatment turns out to be. So that is why I created it. And I was telling Taylor that it has changed a little bit too. It has changed quite a bit, because as my understanding and time has passed, I have changed the order. I've come to understand what was a better order, sequencing, where to put things, what to take out, what worked, what didn't work so well, and so on. So it is it's kind of revised, and being revised as my, as I get to see relationships that I didn't see before. So that's why I taught it. I think one can teach a technique or an approach, and then you must teach the integration of that approach clinically. Otherwise, it dies on the vine. You find people just mouthing about one particular aspect of treatment and making as if it's going to do everything, and it's not.
Well, I think consulting is so much easier than integrating. The true integration piece is so tough. Actually, when we were with Gray Cook, he said something good. He said, he'll have an idea, and then it takes him a year to get that to the point where it would ever be taught. And I thought that was humbling for me to hear that. That's a year's a long time, you know, but through trial and error to see, like, you know.
It does. And I remember when somebody said, well, you know, why don't you teach part 2? I go, part 1's a mess. I don't know what you...
The sequel's never as good.
Exactly, the sequel does. The first book is a mess. What do you expect? I haven't even cleaned that one out. So it's taken a long time. And actually, during this pandemic, I was able to sit and watch paint dry and have my mind work on this.
It'd be creative again.
And be creative and actually go, oh, those slides don't even belong there. You know, and I could take them out and I would test things with patients and go, oh, no, this is what should go in this. And I was able to map it out better. And from then, it grew into, okay, now I can have part 1, which is really the core, the canister, and the beginning of the 4 proximal joints. And then part 2 is integration of the extremities into this. Because how patent the core is, of course, automatically affects what the extremities are going to do. So you have to have an idea that, yes, I've scanned the central area, the axial skeleton. I've done the best I can for it to give maximal potential to the extremities.
Right.
Yeah.
And I don't think you'd ever be wrong on any patient with starting, you know, with abdominal wall, things like that. But I think that the really good clinicians, they understand that, but they're able to, like, they've kind of earned the right to take a shortcut.
You can take a shortcut, and what if you know you're taking a shortcut? That's great. If you don't, that's dangerous. That's the thing. Do you know you're taking a shortcut? Because if you do, you can always come back and look at the trees and rearrange yourself and take the longer route in case you've missed something. But if you didn't even know that you were taking a shortcut, you're in trouble because that patient is going to lose out.
Screwed.
Yeah.
You said something in passing that I think is really good for people to hear, which is basically, in different words, I think I heard you say that principles are what's very important. What the modern day student is wanting is they're wanting an algorithm. This gets a result, but I think this is dangerous in the ability of the doctor to learn how to critically think. And,
That's right.
do you have any ideas on that, like for the?
I think that the way in which, unfortunately, the way in which the professions teach are crippling because they do not insist on an integrated viewpoint of the body. They can pay lip service to it, but when it comes to the classes, they are absolutely divided and structured in such a way that the patient, that the practitioner comes out with everything boxed and separated into in different places. And then you spend the rest of your professional life trying to mix and match this without going mad. I think that, unfortunately, that's it. And secondly, the time constraints that are imposed by economic demands make it very hard for people to spend the time they need with the patient to understand what is going on. And therefore, shortcuts are the order of the day. Each practitioner must decide why he is doing what he's doing. Why did you become a chiropractor if you didn't want to really help?
This is existentialism here. Like, why do I exist?
If
like,
you
what am I?
didn't really want to help, then don't do it. Why
Your
did I
hidden
become
agenda.
a physical
I want to make a lot of money.
Exactly. You can't. If you want to do that, go do it with paper. Don't do it with people's lives.
It's awesome.
Don't do it with people's lives.
Yeah, well said.
If you want to become a physical therapist, it is because you care about what you will be doing. And therefore, you must not bow down to someone else who will dictate how you will practice to the point where you can no longer do a good job.
Heard it a million times before.
That is awful. It is unethical.
Did you have a question?
Yes.
Oh, no, I was just going to kind of finish this up and wrap it up a little bit. I think that's a really good point. I think, going back to your manual therapy course, the thing that I always appreciate and get to sit down with you, with Brett, with the people that we've been able to, is that you keep coming back to the integration word, which is what Gestalt is all about, right? That's what we're all trying to do, is figure out how to integrate all this together and how to put a bow tie on a patient visit that you'd be proud of. Like you're saying, that you go to bed at night and you lay awake, you still think about the things that you could have done, but you feel good about the service that you gave.
Yes.
So, and that's what I think I loved about your manual therapy course, because it added so many different aspects that I had never seen, a different perspective on muscle testing, the trigger point chains, and I think just like you having an insatiable curiosity with a patient. I think that's what makes you an artist. I mean, it really is, and that's what makes the best of the world the best in the world, is this like curiosity about these things that may seem insignificant to another person, but to you may mean the difference in that case. So I think that's what's so amazing with this conversation we've had. Now we're on for 2 hours basically with Robert Lardner, 2.5 hours, but I think. I could sit here and listen to you talk forever because you have so much experience built in. And I've heard it from several people that I trust their opinions, that Robert Lardner has the best hands that they've ever felt. And I think the reason being is because of that curiosity. You've paid attention for now, how many years have you been in practice?
13.
Yeah. So you paid attention to every single practice and every single visit, and you've built all those years of experience in your hands. And that's what we're trying to get these people to that are listening right now, to get them enthused into having that curiosity and to take the time to build those memory traces in your hands.
Yes.
Robert has an ability too to like look at a system and kind of pick out what's good. And I think that's a huge good quality, because I think the typical human being is so binary right now that they can never just think somewhere, you got to be all in or burn it down.
Yes, that's right.
And your ability to like, whether that's information in a book or, because I consider myself like, I'm always searching also. And I feel like anything that I come to you, like you're the one person in the world, like whether it's PRT or whatever it is, like you've heard of it, you've tried it, you know something about it. So I can always bounce ideas off you, because you've basically, you've kept the doors open into so many different disciplines and so many different textbooks, treatment modalities. I mean, it's literally quite amazing. And to be honest, it's very inspiring. So,
Thank you.
Yeah.
Thank you.
Absolutely.
Well, I watched Professor Levitt, and I thought, now that's a practitioner I'd like to emulate.
If I can emulate that,
I know. If I can emulate him, I'd be happy.
Yeah.
Because that is a quality that made him so admirable in all the years I knew him.
Well, and you said too, just a good human. I mean, besides being best in the world at what he's doing, just
Yes.
don't be a dick, as we say. I mean, that's
Rule number one. Don't be a dick.
It won't get you very far.
Awesome. Well, if we could just wrap this last episode up, I think, Robert, thank you.
Thank you
So much. Oh my
Thank you
God.
for the friendship, all the years of.
Holy
Well,
smokes.
thank you.
And be looking out if you see Robert teaching a course near you. Please go. I mean,
We're gonna have him down to our place.
I
next
think
year,
that's a
too.
no-brainer. I was going to say, he looks like he's booking a flight to St. Louis. So anyway, guys, keep being curious, integrate things that, revisit maybe things that also you've maybe dismissed in the past, Come back to them, see if there is a spot that it could fit in. And,
Always ask what if.
Yeah.
Just what if I did this or that? Important.
And if you fail, try it again. Awesome. All right, guys. Well, good luck on Monday. Keep crushing patients and keep having a great curiosity with each and every person that you come across. So I know I'm better off for this conversation. I got a lot to re-listen to this a couple times. So thank you, Robert.
Thank you. Wow.